Thank you so much to Dr. Green for the introduction. My job is to try to get more than 2 to 3 people interested in foot and ankle today. I will say it's a tremendous specialty because you get to do everything. I do trauma, I do replacement, I do sports, I do some pediatrics, I do geriatrics, and so I'll try to give you a flavor of that today. I would say that in my practice, I primarily do arthritis and complex deformity, and so we'll spend more time talking about that today, but that doesn't mean that I'm not doing the other things. So foot and ankle is really one of those specialties where you get to do everything, and it's important that you know how to do everything. So today we're going to talk about one of my passions, which is ankle arthritis. All right, let's see if this works. Fantastic. So we're going to try to go through many things today. We might not get to all of them, but obviously I'm around all week for questions too. So let's first talk a little bit about epidemiology and the etiology of ankle arthritis. Has anybody here, can you just raise your hand if you've seen ankle arthritis in your practices and your offices? People have? Okay, great. So you probably all know that of patients who have limb osteoarthritis, ankle arthritis is relatively uncommon, right? There's 1,000, probably fold more hip and knee cases. And you can look in this breakdown of patients with limb arthritis, only 4% of them were in the ankle. And so why exactly is that? Because raise your hand now if you've seen an ankle sprain or an ankle fracture in your practice, right? So in the United States, there's 2 million ankle sprains a year, 100,000 ankle fractures every year. And while I'd like to think that all of them are being perfectly, immaculately treated, the reality is sometimes they might not be, and yet ankle arthritis is still relatively rare. So even though I'm going to spend the next hour trying to convince you that ankle arthritis is important, I'm also going to tell you that the ankle is actually one of the most arthritis-resistant joints in the body, if that makes sense, that paradox. And so why do we even care if it's really, really rare? Well, first, the patients are really unhappy. If you look at comparable patient-reported outcome scores, patients with ankle arthritis are the same as patients with hip arthritis, end-stage renal disease on dialysis, and heart disease. The two, though, that I really think are important. Oh my gosh, there we go. I think my laser is also not working. I'm so sorry. That's okay. We'll persevere. Oh, I see. Okay, got it. We'll persevere. So the patients are younger. If I had to ask you the average patient that you see with hip or knee arthritis, 60s, 70s, something like that, sometimes 80s, 40, sometimes, rarely. If you had to think about the average ankle arthritis patient, it's younger, right? It's people in their 40s, it's people in their 50s, and it's a very different type of patient. They often have young children or middle-aged children. They often are still working, where the hip replacement patient is retired. They've got grandkids. The ankle replacement patient, they're still working, they're still active, they have kids, they have a life that they want to get back to. These are productive and functional years. And then the final thing that's also really important for the ankle is that the other joints are at risk. If you have knee arthritis, okay, you have knee arthritis. If you have ankle arthritis, now you have to think about the subtalar joint, the talonavicular joint, the midfoot. All of those joints end up being affected because they're compensating for the arthritic stiff ankle that's not working normally. It ends up being a little bit almost like if you think about spine surgery, where if you have arthritis or if you have a fusion at one level, you get that adjacent joint disease. The exact same thing is happening in the foot. The other really important thing is that unlike hip and knee in the modern era, in the era of DMARDs or the medications for rheumatoid arthritis, most ankle arthritis is post-traumatic, and it's about 75%. Now, then the question is, well, what do you define as trauma? And trauma gets lumped as post-traumatic, but it can be a lot of things. It can be an ankle fracture. It can be an ankle sprain with a bad cartilage injury at the same time. It can be multiple ankle sprains, so someone's repeatedly spraining their ankle over and over again. It can be a talus fracture. It can be a pilon fracture. Primary osteoarthritis in the ankle is rare for a lot of the reasons that we were talking about. Inflammatory arthritis is rare. Other, adjacent joint disease, flat foot is also rare. I could talk about this for hours, but I won't. But there's a lot of really cool reasons why the ankle is resistant to arthritis. The cartilage is very different in the ankle compared to the knee. It's actually thinner, but it's more uniform. The ankle is more congruent. It has a very different cartilage biology and biomechanics compared to the knee. And so there's a lot of differences on the basic science side that we won't go into, but that make the ankle very resistant to arthritis. But when it happens, then it's a problem. These are all really important concepts of why some ankle injuries go to arthritis. So Sam Adams and the group at Duke, they actually have been doing this really interesting study where a patient comes into the emergency room with an ankle fracture. And when that patient goes to the operating room for surgery, they aspirate or take fluid out of the joint of the injured ankle and then the non-injured ankle. And they compare that fluid on different cells. And they found that the fracture hematoma, so the blood in the ankle at the time of the trauma, will degrade cartilage. So if I break my ankle tomorrow, I would like it if someone would please wash it out in the operating room. You want to evacuate that hematoma, which has those dangerous cells. The other thing, a couple other things. We know that long-standing ligamentous instability can cause ankle arthritis. I'm going to show you some case examples of that. You continue to sprain the ankle, you end up wearing away that medial talar dome just continues to bonk into the plafond over and over again. We also know that when you first have an ankle injury, you get this progression of chondrocyte or cartilage cell damage. And so you might get an MRI or you might look at it with an arthroscopy at time 0. And I scope the majority of my ankle fractures, but sometimes you don't see a cartilage lesion, but then they come back a year later and what the heck happened? And so there is something where this cartilage cell death starts at the same time of the ankle fracture, even if you're not recognizing it initially. And then finally, we know that different types of ankle fractures may be at more risk for arthritis. And so your standard supination external rotation ankle fracture, one of the more common ones that we see, yes, that can get arthritis, but think about the supination adduction ankle fracture with that medial comminution that happens at the tibia. You're trying to get that joint down. Unsurprisingly, that's going to be more associated with ankle arthritis. The other thing is, people mentioned limb lengthening and deformity. Don't forget to look for deformity proximally. So this patient has bad valgus ankle arthritis, but when you look above, this patient also has a really interesting pattern of deformity at the knee. So this is a case actually from one of my partners who did a proximal tibial osteotomy before we addressed the ankle, because that ankle is just going to continue to have problems as long as the limb axis is out of alignment. So when you look at these patients, the first thing I ask them is, why do you have ankle arthritis? Did you break it a long time ago? Did you have a bad sprain? Did you have bad sprains a long time ago? I will say a lot of patients actually have, when you see a lot of ankle arthritis, a lot of patients have an old tibial shaft fracture that was treated without a nail. So for any of the trauma surgeons out there, please aggressively nail your tibial fractures in a good alignment, because I'm tired of seeing ankle arthritis after that. Arthritis symptoms are pretty consistent: pain, swelling. Patients in the ankle, the hip C sign, people will take their hand and be like, oh, it hurts right here. Patients will do the same thing for the ankle. They'll take it and go, oh, it hurts right here. But specific to foot and ankle, they're going to have difficulty with gait, stairs, uneven ground, inclines. So European cobblestone streets for ankle arthritis patients are the death. They can't do it. They really struggle. You want to ask about what they've tried. So anti-inflammatories, physical therapy, injections. America, everybody's fat, so everybody needs to do weight management. And then orthotics, braces, AFOs, rocker bottom shoes, supportive sneakers. You can be aggressive with your bracing, but patients tend to find that the more aggressive the brace is, the more constricted they feel, and they don't like that. So I end up doing kind of like a lace-up lightweight ankle brace. That's not the textbook answer for ankle arthritis, but it's what most of my patients will end up tolerating. I always, always, always have them stand and I look at their alignment from multiple directions. You'll see in a lot of my talks I have patients standing on our floor, because I think you really have to understand what's happening, not just on the x-ray, but how they actually stand. And then you always want to evaluate not just the ankle joint where you're feeling the gutters in the front of the ankle, but you need to look at the other joints. When I get x-rays in my clinic, it's based on what the patient kind of reports when they come in and they call my office. And so the number of x-rays that I get for people who think that they have ankle arthritis, but they actually have subtalar arthritis, or they have a flat foot, or they have midfoot arthritis. Patients patients are stupid sometimes, and so they think that they have ankle arthritis, but they're talking about something in their foot. And so you have to be really cognizant. You have to look at every joint. So let's talk about x-rays now. So do people have access to weight-bearing x-rays or standing x-rays where you guys are? It's one thing that I would encourage you to do as much as possible, because you do have to try to get the alignment as much as possible. You will see a very, very different picture if you're getting x-rays with the patient not standing. So if there's one thing I can convince you to take back, it would be to try to get weight-bearing x-rays. I traditionally get, always an AP lateral mortise, but then I get a bunch of kind of fancy x-rays. This is the benefit of being at an academic center. I do like to get hip to ankle x-rays to look at alignment. I get alignment views of the hindfoot. And then we'll talk now about some x-ray specifics that we can go to. Okay, so we're gonna start with just a general AP and lateral. Am I allowed to, oh, Dr. Green left. Audience participation is great, so I'm gonna start with you. Okay, so we know it's an AP lateral of an ankle. Talk to me about what you see at the ankle joint. You don't have to stand if you don't want to, whatever feels comfortable, live your life.
First, joint, I'm seeing the arthritis first.
Yeah.
Yes, posterior,
Mm-hmm.
tibial part and the talus, right?
Yeah, absolutely.
Yeah.
Perfect.
And also osteophytes.
Yep.
That you are pointing.
Yeah, exactly. I know. Sometimes I give hints. Yeah, exactly. So ankle arthritis, exactly. You see loss of joint space, you see osteophytes, you see a little bit of subchondral sclerosis. I would agree, a little bit more posterior wear than anterior. Talk to me, the next person in the blue collar shirt. What do you think about the alignment? This is the first case, so my guess, I'll usually start with an easy one and then get harder. You think varus, valgus, or neutral? Varus, valgus, or neutral? A little, maybe like under a degree. This looks pretty neutral to me. I'll show you some crazy ones, I promise. And then sagittal alignment also looks pretty reasonable. I agree there's a little bit more wear here, but this for me is a neutral ankle. If I see this in my practice, I'm like, it's gonna be an easy OR day, Okay, so now I'm gonna start with you in the boss hoodie. Okay, different date patient, what do you see here? Syndesmosis looks okay to me. Talk to me about what you're seeing at the ankle joint.
The space is narrowing.
Yeah, exactly.
It's all the space is narrowing.
Uh-huh. Would you?
We have a little bit fusion in the corner there.
Yeah. Major joint space narrowing here.
And varus deformity.
Mm-hmm. Varus or valgus? Valgus, exactly. Awesome. Sorry, this pointer is gonna make me jump off a bridge. Okay, talk to me about the plate here. So what did this patient probably have? Yeah, exactly. So they had a fibula fracture. Thank you. So they had a fibula fracture. Listen, I think that overall the length, but it's still. Maybe I'm blocking it? Okay, that would be awesome if that were the case. Okay, so the fibula looks to me to be pretty well aligned, but you can imagine that if they fix this fibula short, it might be that this patient collapsed into valgus ankle arthritis. Even though this is valgus, this still isn't that severe, okay? But this is another post-traumatic arthritis, okay? All right, this is a different one. Let's go to you in the tie. All right, what do you see? Say that again. Arthritis. Varus, valgus, or neutral? Varus, exactly. Do you guys see any evidence of fracture in the past? Yes or no? I'm going to tell you right now the patient has no history of fracture. Okay, so talk to me about the shape of the talus here. Is it square or rounded? Rounded, right. Okay. So who knows what ligaments are torn in an ankle sprain? There's two big ones. Yep. Exactly. When you sprain your ankle, what two motions does the ankle go into? There's one in the coronal plane, one in the sagittal plane. Varus? Oh my gosh, almost like that. Yeah, great. What's the other one? Like anterior translation, is that what I heard? Kind of the ankle comes forward. It's like a rotational injury. It's almost like an ACL, you know, comes forward and out. So this is chronic. Oh, we'll go with our lights again. Whoever called that my finger was on the pointer was totally right. Good job. So this is chronic instability. Very, very classic of chronic instability. This patient has probably been spraining their ankle for the last 30 years. Now they're stuck in varus ankle arthritis. The talus is rounded because they've been spraining their ankle, and the talus has literally been rolling around in the plafond. It's almost like when you go to the sea, you sharp glass that gets rounded over time when it's been in the ocean. The same thing happens to the talus. Okay. All right, so we already talked a little bit about neutral plane deformity of arthritis. So here is another one. Is this varus, valgus, or neutral? Valgus, right? You can actually have valgus from chronic ankle sprains as well. It probably just means that you've had more deltoid injuries, but you can absolutely have like a valgus instability arthritis, okay? I think the biggest misconception is that chronic ankle sprains always result in varus ankle arthritis, but that's not the case. Okay, so interestingly, there's a couple different types of deformity, even in the coronal plane. So when we talk about a congruent deformity, it means that when you look at these two yellow lines here, the plafond of the tibia and the plafond of the talus are matching. But if you look at the overall axis, is the ankle varus, valgus, or neutral? Varus, right. But why are they in varus? Exactly. Again, this is my plea. Please nail your tibial fracture as well. This is a different one. This is a little bit like that instability one that we were talking about. So this is an incongruent deformity. See how the tibia and the talus don't match, but the tibial axis? That's an incongruent deformity. And so you have to think about these things because they're going to affect your management. Are you going to correct the deformity proximally first? Are you going to have to do additional procedures to balance the ankle at the same time if they have chronic ankle instability? So we talked a lot about the coronal plane. Now let's talk about the sagittal plane. Okay, so I forget where I was. Maybe you in the black shirt and the gold watch there. Can you tell me what you see in the sagittal plane?
Joint space decreased, especially in anterior.
Exactly. I think, could I argue with you that it's not just decreased anteriorly, but the whole talus is translated? Exactly. What cause of arthritis does this patient have? If you had to guess. Exactly. So chronic ligamentous injury can result not just in a coronal plane problem. This person has pretty neutral coronal plane, but sagittally, they can absolutely have a sagittal plane deformity. And anecdotally, these are a little bit hard. These are way, way harder to correct. I can take 40 degrees of varus or valgus and get it corrected pretty easily in the OR. These are hard. These are really hard. Okay, here's another one. So I'm going to ask you in the cool watch. All right, talk to me about what you see here.
Okay, so on the frontal plane, there's no varus.
Yeah.
And on the sagittal, the talus is protruded, it's back.
Exactly. What do you think caused this person arthritis? I'll give you a hint. It's the same answer as before. Also ligamentous instability, right? So this is someone who's kind of, I will argue that this is a really another challenging sagittal one to cause. This is also chronic ligamentous instability. So I think the big thing for this is ankle arthritis is post-traumatic, but post-traumatic can result in many different patterns or types of x-rays. So if you look at here, you can see how much the talus, and you have to correct that at the time of surgery. If you don't, you will, one, your replacement or whatever you do is going to fail pretty rapidly, but two, the patient's also going to have symptoms. So for me, in my hands, this ends up getting a rostrum, like a lateral ligament repair, typically either a gastroc or a tendo-Achilles lengthening, and often a deltoid peel, all at the exact same time as the replacement. You have to correct that. Okay, I am not a big fan of classification systems, so I'm going to skip this section. I just think that the ones out there are not helpful. There's like one from the Japanese, but varus arthritis is really, really common in Japan and Korea, but I don't think they account for as much of what we just talked about, so I'm just going to skip that. Okay, so non-surgical treatment we always offer to patients first, and it's pretty standard. Activity modification, ice, a good rocker bottom shoe. In the United States, the brand Hoka is a very common one, but anything that's stiff that has a rock, patients tend to do better with. There's lots of braces options. My patients tend to like this one. Physical therapy, injections, anti-inflammatories, etc. I don't think there's anything magical or special that's different here. My algorithm, I do use activity modification and NSAIDs. I give people a brace. This is like one of the more textbook answers, but again, most patients hate this one. I give everybody a rocker bottom sole. I will do injections to a point. I think if you're 50 and healthy and at some point going to be a surgical candidate, I don't like people overloading the ankle with steroids. It'll muck up the cartilage and it'll muck up the soft tissues, more importantly. For my 80-year-olds with bad heart disease who are never going to get surgery, I'll inject them until they die. Like, that's fine. The physical therapy is okay to try, and then weight management obviously can help. There's a nice study, I think, from Duke that says that every increased pound, or every time you take a step, especially going upstairs, you put like 6 times your body weight on your ankle. So I try to do a lot of counseling for patients like, oh, if you lose 5 pounds, your ankle sees a 30-pound weight loss, trying to like motivate people like that. I don't tell them if you gain 5, it's like adding 30 pounds. This is, by the way, what steroids looks like in the ankle joint. This is a patient who is young, who had a lot of injections, and you can see it just leaves these gross deposits everywhere. So again, if I'm thinking about a patient who might need surgery, I'm like, you get 2 injections. You get one for your family trip to Europe or whatever, and then you get another one for like your kid's wedding and you want to dance, and then we're doing surgery. So let's talk about treatments now. Any questions so far? Great. So let's talk about treatments, and even though I love replacement, we're going to spend a lot of time talking about kind of multiple other options out there. So you can break down your operative treatments into 2 groups, joint preserving and joint sacrificing. For joint preserving, we're going to talk about 3. Arthroscopy, debridement, and biocartilage, which is kind of like not a real treatment for arthritis, but we should still talk about it. Distraction and SMO. And then for joint sacrificing, there's fusion, there's replacement, there's TTC. Okay. So, there's really good data in orthopedics that says that arthritis should not be treated with arthroscopy and debridement, right? We all kind of know that. I'll give you one exception. If you have in the ankle mild to moderate cartilage wear, but a focal osteochondral defect, that might be a reason to do scope debridement and cartilage repair. But that would kind of be the only one that I would do it in. So here's a patient who was in my office who was like 65, and his ankle joint looks pretty good, but he had a lot of pain. Well aligned, he's got good motion, maybe a little bit stiffer than the other side. And when you look at his MRI, so this is a proton density sequence. It's not the same as T1. Proton density will show you more cartilage. So we're looking at the ankle joint. Black is the end of bones, gray is cartilage. And you can see his cartilage there, it should be kind of uniformly gray all the way through when it's not. It's kind of diffusely worn, but then he also has this focal osteochondral defect in the medial side. This is one that I think, and I'm sorry, I think he actually deferred surgery, but this is the one kind of exception where I would have treated him with scope osteochondral lesion repair without doing anything, because there's just too much cartilage there that replacement I don't think would be helpful. And if you look at the knee replacement literature, patients who are given total knee replacement when they have mild to moderate arthritis just don't do as well. And we haven't really studied that for ankle yet, but I'm going to extrapolate and assume that that is true as well. Has anybody seen distraction?
I've done the last week.
You've done this, okay, perfect. So distraction is a technique where you use an external frame to pull the ankle apart. And I will say we have it a few surgeons at our hospital who do it, so I see a lot of it. I personally don't do it. We're going to talk about why. You know, theoretically what happens is that you can get fibrocartilage in the defects, and that can help with a patient with ankle arthritis. And a lot of times you see it for patients who are really young, because as we talked about, ankle arthritis is post-traumatic. And so if you have a bad ankle fracture when you're 18 years old and you get arthritis by the time you're 25, well, replacements and fusions when you're 25, that's a hard discussion. You know, it's kind of once you open that box, you're wedded to that box. You know, it's like marrying someone. You're like, you and that patient are in it forever, you know, and I don't have enough gray hair yet. So it's at a certain point, it's like if I'm doing a replacement on a 30-year-old, it's like you and I are together for the next 30 years. So this is a very, I think, it's an option that people have a lot of curiosity about. I will tell you that I probably am biased because I see the people who it doesn't work out in. And I will tell you that anecdotally in my practice, it makes the ankle replacement or the fusion harder. And they're just not as happy because they get kind of stiff. All the soft tissues get stiff. I think expectations is a big part of it. So I am not a huge fan of it. Anecdotally, I am more likely to use replacement in a young patient, understanding in a well-counseled patient, understanding the risks, or fusion rather than distraction. But I'll show you a case from my fellowship. So not one of the ones that I did with one of my my partner. So here's a patient, and he's like 29. So kind of age of a lot of people in this room, I think. So he's got ankle arthritis. What do you guys think about this hole in the calc? Good thought. So I'm actually going to say no necrosis. He had a graft procedure where they took bone graft from his calc. He also has this kind of line here, which is fracture, or this is our what am I thinking question. Yeah, exactly, medial approach. So they probably did like a medial osteotomy with either an OATS, so like taking cartilage from the knee and plugging it in, or an osteochondral allograft, so taking cartilage and bone from a cadaver and putting in. And despite all that, he still kept on getting arthritis. His subtalar joint looks like garbage too. So here's his MRI. You can see the old cuts from his medial osteotomy. You can see he's got crappy cartilage in there. And the bone here does not look good, nor does the cartilage. So we scoped him, repaired the cartilage defects with biocartilage, which is a cartilage matrix graft mixed with BMAC from the iliac crest. And then after that did distraction. So this is his joint, which looks like garbage. We actually integrate drilled his tibia, backfilled that with biocartilage, and then put biocartilage like everywhere. And when you look at the distraction, you can see how much distraction they got at the ankle joint. But I will also tell you that he's now like 3 years out and is still in pain. So I think short term it may help, in the right patient it may help, but I just haven't seen it work personally, bias. Okay, so now let's talk about supramalleolar osteotomy. Has anybody seen or heard these? So I actually love SMOs. They actually really started in Asia, where congenital varus arthritis and deformity are quite common. In the United States, I think that they're less common. Our results initially weren't as good, but I think in the well-indicated patient with appropriate expectations, it can be a very good option. There's a lot of different types of SMOs or supramalleolar osteotomies. So you can do an opening wedge, more commonly done on the medial side, But then your question is, okay, and I corrected it, and that a lot of time is for like a varus arthritis. But then it's like, what do I put in my defect? You know, do I take allograft? Do I have to go up to the iliac crest and then take that? Do I use a metal wedge, which some companies make? So then you have to deal with all your graft healing options. You can do a closing wedge, which works fairly well for a valgus arthritis patient. But again, for our osteotomies of the SMO, we tend to go medial rather than lateral, because laterally you've got important neurovascular structures and the syndesmosis, et cetera, to go through. It can be a little bit more challenging. And then there's something called the dome, which is through an anterior approach, where you actually make this curvilinear cut here. And it's great because you get bone-to-bone healing and this really great surface. It's technically the most challenging of them. It can also very easily translate, which is not always great. So we'll start with this patient. She's 41. This is, I think, one of my partner's cases that I stole. So talk to me. I'm going to have started here, or we can keep on shouting at, whatever you prefer. Talk to me about what you see. Her pain is kind of medial ankle. Does she have horrible arthritis? No. Is she varus, valgus, or neutral? Varus. Is her deformity congruent? Congruent, right? So this is not someone who's got chronic varus from chronic ankle instability. This is someone who's got distal tibia varus. And so for her, here's her MRI. You can see sclerosis of the bone medially. You can see cartilage wear medially. And she was treated with a supramalleolar osteotomy. This is an opening wedge using an allograft soaked in BMAC. And you can see really nice correction of the ankle joint there. So that is a very reasonable option. Now we're going to get to my cases, so you'll see kind of what technique I favor. So this is a really interesting one. So she's like early 50s. She's a wine distributor or something. She like walks around all the city like carrying like 18 bottles of wine in her backpack. She sprained her ankle a ton. So because we talked about ankle arthritis subtypes, we can say, okay, she's probably like a post-traumatic type of ankle patient. But look at how much her talus is translated medially. You guys see that? There's like this huge gap between the talus and the fibula right here. And she also has this bowing of the tibia into varus. And so even if you wanted to do a fusion or a replacement on her, she's in her 50s, so she's young, but not unheard of. You got to get that talus back, you know? Because if you put your implant, let's say we're doing a replacement, if you put your implant on your talus and your implant on your tibia, there's going to be a mismatch. They're not going to line up together, and you're going to have rapid failure. What's up?
To correct the alignment of the tibia.
Exactly. You have to correct the alignment of the tibia. So I did a dome osteotomy, which actually is my preferred technique. It's technically challenging, but I really, really like it. So the also thing, the reason why I like it is because you do an anterior incision. I'm going to use that for my total ankle later. You can do it freehand. They also make guides. So the first few in practice, I did freehand, and then I switched to guides, and it made life way less painful. So there's a guide that you put on. You make sure it's nicely lined up in the sagittal plane, unless you want to correct the sagittal plane deformity as well, which you absolutely can with the dome. You can do multiplanar osteotomies. You drill through these holes, and then you complete them with an osteotome. It results in something like this. You do have to do the fibula, otherwise it won't work. So the fibula you just do freehand under X-ray. And then you rotate. You literally just rotate the foot and you put it wherever you want it, and then you pin it, and then you fix it. And you can see that you get really great correction of the distal tibia. But what's so amazing is the talus comes over when you do that. And that's a really, really powerful correction that I don't think you get with an opening wedge. Here is her at about a year or 6 months out or something like that. They do take a while to heal. You can see she has a fair amount of callus there. She probably drifted back a little bit. I could have even overcorrected her more. I think being critical of myself, like here it's neutral. and I probably should have put her in a couple degrees of valgus first, but she's like so happy. And I told her, okay, you ready to do your total ankle? And she's like, absolutely not. So this can be a really, really great option. So you can also do it for valgus. Yeah?
Do you go the posterolateral approach here?
Nope. I did direct anterior and then direct lateral for the fibula.
So how do you put the plate in the back?
It's in the front. It's on the, yeah, the tibia plate? Yeah, the tibia plate's in the front. I put one screw up the medial mal, and then I put a plate on the tibia. It's kind of like an anterolateral, like pilon plate.
One approach.
Yeah, one approach. Well, and like a little one for the fibula, but for the ankle, just one. And then I'm going to use that approach again for my total ankle or my fusion, but I'm a replacement person. So you can also do it for valgus. So this is a lady who is like 60. She's always had a flat foot, but she also broke her ankle and someone told her that she didn't need surgery. So you can see she's got a fracture deformity of the fibula and the fibula shortened. And now she's in a tremendous amount of valgus. And so when you think about options for her, well, yes, if you truly wanted to undo what was done, you could do a fibular lengthening osteotomy, but that's hard. You know, when you think about deformity, lengthening things are hard. It's a lot easier to shorten to correct deformity. And in addition, she probably had some type of subtle tibial fracture that was missed, because otherwise I don't know how your tibia gets this crooked. And she's flat. So for her, she also got a dome osteotomy, but you just reverse it. So you do the exact same, you cut here, you just rotate it the other way, you make it neutral, fixed it. And then I also cut and slid her heel. I did a medializing calcaneal osteotomy because she was flat. Ultimately, I told her down the line, I would like to do, I want to fuse her first TMT. She's got a bunion, some midfoot arthritis, but this was too much surgery for me after one case. So I was like, we can do that 6 months down the line. She's not taking me up on that offer yet, but I think the alignment looks awesome. And so, you know, again, this is one that I did earlier in practice. I would have probably overcorrected her, but I think overall I'm still very happy with her alignment, and she's nicely healed. You can see how she's got like midfoot arthritis and plantar gapping there that I want to fix. So now let's switch gears and let's talk about joint sacrificing treatments. So, oh yeah, sure.
Because I was seeing those totally, do you do something for to help the cartilage, the tendinopathy to heal after the surgery?
Wait, say that again?
Injections maybe with, do you help the joint?
Oh,
Surgery?
I don't touch the joint at all for these. I will sometimes put in some type of biologic off the shelf to promote osteotomy healing, but I typically leave the joint alone. I stay extracapsular.
Okay.
Yeah. The nice thing about the dome is that even though it does take some time to heal, you have these two really broad surfaces of bone that are not, like distal tibia metaphyseal bone is good. It's bloody, it's thick, it heals pretty well. Yeah.
Do you always put this needle at the home run spoon?
I like it lately. I might switch gears and do 2 plates, but I like it because very easily it can deform in the sagittal plane because you're making this cut in the front, and often we take more bone accidentally in the front and it can kick it into a little bit of dorsiflexion. So I kind of like the home run screw first just to stabilize it, and then I've got my other wires in, and then I just put my plate on top of it, and then it's just sawbones.
Are you taking the full leg length x-rays?
I am, but most of for these cases specifically, it was like a distal tibia deformity. If there is something proximal, a lot of times I'll do it with one of my partners who does HTOs and DFOs and stuff. Awesome. So we'll switch gears now and we'll talk about joint sacrificing treatments. And so this is kind of my slide for my patients, which I say your real options here are fusion and replacement. They're both terrific for pain relief. I have a bias for one. And we know fusion, it's been around for 100 years. It's good for pain, it's good for deformity. And once it heals, I tell my patients, the pro of this is you never have to come back and see me again, which some people like.
You can do it open, you can do it arthroscopic, but we know the downsides. You take away the ankle joint motion. And what happens is then the other foot joints can also get arthritis because they are compensating for it. And there's some really great studies in the literature that show this. So I am from Nebraska, which is in the middle of the United States. It's like farmland. Nobody leaves except for me. Where I'm from is next to a state called Iowa. Iowa is also farmland. Nobody leaves. And the only difference between Nebraska and Iowa is that Iowa had a really great foot and ankle department early on in like the 1960s, 70s, 80s. So like Ponseti casting for clubfoot. Have you guys heard of that? That's University of Iowa. Part of the reason it worked is because Ponseti was awesome, but the other reason why it worked is because they had like 40-year follow-up because no one in Iowa leaves. And then they followed their kids, and then they followed their grandkids because no one leaves. And so if you look, they also have studies from Iowa in ankle arthritis, and they've got 30-year follow-up because no one leaves. And they found that patients who had ankle fusions or even just ankle arthritis all developed midfoot or hindfoot arthritis down the line. It's not right away, it's like 10 or 15 years, but it happens. It happens in everyone. So on the flip side, we've got replacement. We can preserve ankle joint motion. Notice I say preserve, not give, because similar to total knee and hip, your preoperative range of motion dictates your postoperative range of motion. But if you look at gait studies, the patients have much more natural gait. They have longer stride length. They do better on uneven ground and incline and stairs. And we also know that we can protect the other foot joints. They may still get arthritis of the adjacent joints, but it will happen probably at a slower rate. Downsides, like all replacement, parts may need to be exchanged or revised. Surveillance, so patients need to come and see me. I pretty much do x-rays every year, every other year for them. And then the long-term survival of current implants is still something that's very important to take into consideration. The modern implants that we're using for total ankle replacement are all pretty much under 10 years old. Some of them came out in 2013. A lot of them came out 2014, 2016. So we can extrapolate to what happens, but realistically we know there's about a 95% chance of success at the first 2 to 5 years. That probably goes down to 90% at 10 years, 85% at 15, but we're just statistically modeling and guessing at that point. We truly don't know. So this is a really great paper from JBJS in the 60s, and it looks at how did people do after ankle fusion. And we think about, oh, fusion's a great operation, but it really isn't. These patients have non-union, they've got calf atrophy, they have worse gait, they have trouble walking without shoes, and they have degenerative changes in all of patients in their subtalar joints and the midfoot. I will say that in the right, today though, ankle arthrodesis or fusion can still be a good operation for the right patient. There's a lot of different ways to do it. You can go lateral, you can go anterior, you can do a 3-screw construct, you can do a plate and 3-screw construct or just a plate and screw construct. They have posterior plating, you can do a TTC if you need to incorporate the subtalar joint. So you can be really flexible with this, and I think I have a case maybe later today or tomorrow that we'll talk about more. But let's switch gears and talk a little bit about ankle replacement, because this is my bias of what I love to do. So these are the old replacements, and if you've seen these, the early generations were absolutely horrible. The first replacement that they did actually, well, depends on who you think about. There's actually one from Iowa we can talk about later. That was like a custom total tailor prosthesis. But the first replacement that they did was in France, I think, Lord and Murat. And they just took a hip replacement and they put it upside down and they jammed it upside the tibia. And then they cemented the polyethylene liner into the talus. And they were like, this is gonna be fine, right? It did not. So they really just didn't know what they were doing. And that's okay. This is how we innovate in orthopedics, as we try things. We learn from our other subspecialties. But they really weren't doing very well, and they weren't balancing the foot. Tons of soft tissue stripping. It was horrible. And this is where we are today. So we have a lot of low profile implants here, which minimize bony resection, which can be nice, especially if you're thinking about that young patient who might have multiple revisions down the line. But then we also have stemmed and revision implants, which we can use for more severe cases, cases where there's loss of bone stock, or cases where you need a more constrained, robust implant. Also, if you correct the deformity at the time of surgery, there's really no different in outcomes. So as long as you can make the ankle straight at the time of surgery, you can pretty much take on whatever deformity you want. But you have to balance the ankle, and I cannot stress this enough. So if you look at a consent for one of my total ankle patients, it will say total ankle replacement, and then it'll list like 18 procedures listed as possible. And I would say it's very rare that I just do a total ankle replacement. Most of the patients that I see have deformity, so at the same time I'm doing a deltoid ligament release, a tendo-Achilles lengthening, a rostrum, that's kind of like one workhorse. If they've got more of a flat foot, I might end up doing a calc, like you saw in my SMO case, like they're doing a calc slide, I'm doing a gastroc, I might do a first TMT. But you have all of these in your toolbox because the ankle and foot both need to be perfectly balanced, otherwise your ankle will fail. So here's a patient who he was young, he always had a flat foot, he had an ankle fracture that was fixed, but he still collapsed. So you can see, they did a deltoid repair at the time of his initial surgery, but he's still really flat, and you can see the extensive amount of valgus he has in his ankle. And so this is one that we staged, but he got a stemmed implant, he got a heel slide, and then 2 weeks later, just to give him a little bit of soft tissue rest, a first ray procedure, so a Lapidus and then an Aiken. So you can correct him, you can correct his deformity. That's what he looks like now, but you just have to make everything straight, otherwise he will fail. Here's another one of my patients. So she has a really medially translated and rotated talus from her arthritis, and she also has kind of this high arched foot. So for her, she also had a stemmed implant. I a lot of times will put a screw in medially to protect from stress fracture, especially in women or people with poor bone quality. These anchors are from a rostrum for a lateral ligament repair, and then she also got a first ray dorsiflexion osteotomy to bring the first ray up. So again, this is like a very common total ankle replacement day for me, where you have to do those additional procedures all at once. So we had these like old rules for replacement, and these old rules were, okay, well you can only replace it if the patient's elderly or low demand, or if they have rheumatoid arthritis. You can't do it if there's deformity. You would never do an additional procedure. And if they're already stiff, well, just fuse them. Just fuse them, they're already stiff. The new rules, I think, are much different. Most patients can be candidates. You just have to be cautious. And there was a really interesting paper that came out of Duke in JBJS that I think is in press or just came out. And it said that patients who are younger who get ankle replacement don't do as well. And that may be true, but think about all the other factors that go into a young patient with ankle arthritis. They probably had a fracture when they were 20. They've lived through their 20s miserable and in pain and watching their friends do things that they can't. They might have had multiple surgeries. They probably have had a scope and a hardware removal and a cartilage procedure. And so I get it. Like, those patients might have higher expectations. They also might be putting more pressure on their total ankle. That being said, I would still favor a replacement for a younger patient because of protecting the midfoot and because our revision options are better. You can take on deformity as long as you balance the ankle intraoperatively. So you can take on 20 to 30 degrees if you can get it straight. If you can't get it straight, then fuse it. But if you can get it straight with your additional procedures and your balancing, you absolutely can take on deformity. You can maximize additional procedures to balance the foot. And for that patient who's already stiff, I would actually argue that a little motion is better than no motion to preserve the adjacent joints. So I've still replaced patients who have like 10 degrees of motion because they end up first of all, they end up being happy. And second of all, I like to think that I'm protecting the subtalar joints still more than I used to. That being said, if you fuse it, you still have to make sure that the ankle is well aligned. You can't just be like, oh, but